Welcome to today's Explainer. I'm so thrilled you're here because we're unpacking something absolutely fascinating today. We are exploring a super high-stakes intersection in neurocritical care, traumatic brain injuries, and sodium. Now, I know that sounds incredibly specific, but as you'll see, beautifully illustrated today with our animations on this crisp, pure white background, the stakes literally could not be higher. Right, let's dive right into this mystery. When we think about severe head trauma, we almost always picture the physical impact, right? The visible damage. But long after that initial injury, there is this invisible, microscopic balancing act happening inside the body. A simple grain of salt, or, well, more accurately, the sodium ion, becomes one of the absolute most critical factors in deciding whether a patient recovers or faces a catastrophic decline. Section 1. Inside the rigid skull. To really get why sodium matters so much, we first have to look at the physical environment of the brain itself. Okay, so this brings us to the Monro-Kelly doctrine, which is basically the foundational rule of neurocritical care. The human skull is, for all intents and purposes, a rigid, closed box. And inside this box, you have exactly three things: brain tissue, blood, and cerebral spinal fluid. Because the box absolutely cannot expand, if just one of those components increases in volume, the pressure inside the skull, the intracranial pressure, has to go up. The brain has literally nowhere to go if it starts to swell. So even a few extra drops of water can be totally devastating. And this is exactly where sodium enters the picture. I want you to think of sodium not just as some boring lab number on a chart, but as an invisible, highly powerful magnet. Sodium is the primary determinant of plasma osmolarity. Basically, what that means is, wherever sodium goes, it pulls water across the blood-brain barrier right along with it. It acts as the master lever controlling the water content inside the brain. So what happens when that lever gets pulled in the wrong direction? Well, that brings us to Section 2, the danger of low sodium. Dropping sodium triggers a truly terrifying cascade. When sodium levels in the blood drop, plasma osmolality falls. Because the concentration of solutes is now lower in the blood than it is inside the brain cells, water just rushes into the brain to try and balance things out. The brain cells swell up, a condition we call cerebral edema. And remember our rigid box from earlier? Yeah, as the brain swells, intracranial pressure spikes. This cellular swelling can cause severe headaches, seizures, confusion, or, in the absolute worst-case scenario, a deadly cerebral herniation, where the brain is physically crushed against the base of the skull. Now, the detective work required to fix this is so incredibly fascinating. Low sodium after a head injury isn't just one single disease. It usually comes down to two very different culprits. On one side, we have SIADH, where the body inappropriately holds on to way too much water, diluting the sodium. But on the other side is cerebral salt wasting, where the kidneys actually dump sodium and fluids straight out of the body. Both give you low blood sodium, sure, but their underlying mechanics are complete opposites. And here is why that matters so much. A doctor absolutely cannot simply look at a low sodium number and guess the treatment. If a patient has SIADH, restricting their fluids is a standard, really helpful treatment. But if that exact same patient actually has cerebral salt wasting, meaning they are already dangerously dehydrated and losing salt, restricting their fluids will drastically reduce blood flow to an already injured brain. Misdiagnosing the cause can literally starve the brain of essential oxygen and nutrients. All right, let's flip the script and shift our focus to Section 3, the risks of high sodium. This is what happens when there is far too much salt concentrated in the blood. This imbalance often paints a picture of a condition known as central diabetes insipidus. It's a really dangerous hormonal chain reaction. The initial physical trauma of the head injury ends up damaging the hypothalamus or the pituitary gland at the base of the brain. That damage halts the production of ADH, the antidiuretic hormone. Without ADH telling them what to do, the kidneys basically go into overdrive, dumping massive amounts of highly dilute free water into the urine. The body loses water so rapidly that the sodium left behind in the blood becomes dangerously concentrated. And this creates a terrifying vulnerability for the patient. Think about it. If you or I started losing that much water, we would experience extreme thirst and just, go drink a big glass of water. But patients with severe traumatic brain injuries are often unconscious, heavily sedated, or on a mechanical ventilator. They're losing massive amounts of free water, but they're physically trapped, completely unable to save themselves by taking a drink. It is entirely on the shoulders of the neurocritical care team to recognize that rising sodium and intervene. But hey, sodium isn't always the villain in our story. Section 4, using salt as therapy. In the right hands, salt is actually a highly calculated medical weapon. When a patient's brain is swelling dangerously, doctors utilize something called hyperosmolar therapy. They will intentionally administer a hypertonic saline, which is a very highly concentrated salt solution, directly into the bloodstream. Because of that magnetic osmotic pull we talked about, this sudden spike in blood sodium literally sucks the excess water right out of the swollen brain tissue and back into the blood vessels. They aren't just raising sodium for the fun of it. They're actively physically shrinking a swelling brain to save the patient's life. It's amazing. Section 5, monitoring the delicate balance. Because, of course, deploying the weapon like that requires intense, continuous surveillance. To safely pilot the brain back to equilibrium, a medical team is juggling serial data points around the clock. They're constantly checking serum sodium, serum osmolality, mapping every single drop of urine output and its concentration. They're tracking urinary sodium, total fluid input and output, daily body weight, renal function, moment-to-moment neurological status, and live intracranial pressure. It is just a staggering, exhausting symphony of data collection required just to keep that one master lever in check. And they have to be so incredibly careful, because in this balancing act, rushing back to a normal number too fast is honestly just as deadly as the initial injury. There is a severe whiplash effect if you correct sodium too quickly. If a patient has had low sodium for a while and you push it up to normal too fast, you can trigger osmotic demyelination syndrome, which is literally stripping the protective coating right off the nerves in the brainstem. On the flip side, if their sodium is very high and you drop it back to normal too rapidly, water will just flood back into the brain, causing massive rebound cerebral edema. The correction has to be highly individualized, incredibly slow, and meticulously controlled. So how do they actually do this at the bedside? Well, here's the practical step-by-step approach. First, determine the direction. Is the sodium trending up or down? Second, assess the patient's fluid volume and osmolality. Third, play detective and identify the underlying cause. Are we looking at SAADH, cerebral salt wasting, or diabetes insipidus? Fourth, correct the imbalance incredibly slowly. And fifth, monitor repeatedly, over and over and over again. There's a guiding principle here that you really have to let sink in. The goal is not merely to normalize the sodium value. The goal is to protect the injured brain. Sodium is not just some lab result to be fixed on a piece of paper. It's a dynamic, real-time marker of the brain's survival, intimately tied to water balance, pressure, and the very flow of blood that keeps those injured neurons alive. And that leaves us with this final, really provocative thought. When we peer into the incredible complexities of human biology and neurocritical care, we constantly have to ask ourselves, in the delicate balance of the human brain, are we treating the numbers or are we treating the patient? Because as we've seen today, focusing blindly on a number without understanding the deeply interconnected biology beneath it can be a fatal mistake. Thank you so much for joining me for this explainer. I hope it sparked your curiosity about the sheer resilience and fragility of the human body.